69-year-old male patient with capsular pseudoexfoliation on whom we operated some time ago due to dislocation of the intraocular lens in his other eye with the same surgical technique. An upper and lower peritomy is performed in this case, taking as reference the position of the haptics to be sutured. We make a triangle or scleral flap to be able to bury the polypropylene suture so that it remains hidden in the sclera. We use a diamond scalpel for this. Due to the fact that pseudoexfoliation is a very frequent pathology in our environment, we have been suturing intraocular lenses with the same surgical technique for more than 20 years. We do this with lenses of different haptics, whether they are 3-piece, double loop or single loop. We placed a double needle 9.0 polypropylene suture below the haptic of the lens and take it out through the retroiridian space between 1 and 2 mm from the limbus. Then we pass the other needle through the upper part of the haptic, and in this way the lens is held, embraced by the polypropylene suture. With the same suture we pass under the scleral hatch. We try to leave a flap to be able to suture it so that the haptic remains in its corresponding place. We adjust well and make 3 or 4 knots to make sure it doesn't loosen. These patients usually have pupils that do not dilate well, so we use high-res hooks or retractors to help us better observe the lower haptic, which in this case it is inside the capsular bag and it's surrounded by a summering ring. We get a 25G needle, we thread it above and another below the haptic to lasso it. And in this way we retie the polypropylene suture, leaving the intraocular lens inside its capsular bag, but inserted in its corresponding place once again. We sutured the conjunctiva. To date, the patient has recovered his pre-subluxation vision of 20/20.